started. I pledge allegiance
to the flag
of
of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you. I don't see any public, so I guess we don't have any public comments at the moment. So we'll move on to the consent agenda, and I didn't see any, we were going to have surplus items. I didn't see
We
that.
did not have any that we needed to designate.
All right.
So if we don't have any, we won't bring them to you. If we do, we will.
Yeah, but there's still going to be other consent.
Yes.
Okay. So move to the consent agenda items.
I don't have to second.
Moved and seconded to approve consent agenda items. Those in favor?
Aye.
Aye. Thank you. Let's see, financial report. Cheryl, you're right on the ball here.
All right. We had a great month. I think I added a few reports to the reports that I sent out to you that maybe you noticed. I said,
Changed a few.
yeah, did I?
I think so.
Maybe I did. Always trying to improve it, but I did send you some information on capital spending, and I also sent you some information that was a aging of our accounts receivable, and kind of showed which buckets were going up and which were going down. I also highlighted on our detailed balance sheet where we were talking last month about the Patricia Ganey Johnson Fund and what was the balance. And if you look on that detailed balance sheet, I highlighted the line because that fund does have its own line on the detailed balance sheet. And that balance is $95,000, almost $96,000. So I think, I hope I wrote a good narrative with lots of information, and I'll try to keep this sort of brief. Like I said, February was good. This number right here, with 13 swing beds, kept us extremely busy. Year over year, we actually have 133 patients less than last year at this time. A big drop is here in emergency patients, but I think that has quite a bit to do with the 1,033 people that we saw in our clinics in February. That drop for ER is only a 3% drop. It's not really significant, but it was an anticipated decline. Our ancillary services are all doing extremely well. I mean, lab is busy, rehab is extremely busy, home health has been sailing along, and the clinic is huge. Radiology is just very close to where we anticipated it would be for the year. So this is our average monthly revenue for this year, 2016. It's at $2.361 million. Our revenue for February was actually 2.47, so that's above average. It was a very good month for revenue. Our days in AR is right here. It's dropped to 77. Our average for the year is at 78. We continue to be very focused on the issues around receivables and collections. We have an update on some of our issues if you're interested. I think the most important update that I want to mention is the fact that we've been struggling with being on hold because of the cost report and then because of credit balance reports with Medicare for use late. And we actually received money today, so that's a signal that we are finally resolved our issues with them and we can start sending bills. Otherwise, our issues are ongoing, and we actually continue to make progress and resolve them. So I do anticipate the days in AR will continue to go down. Our cash collections for the month have been very good for the last several months. Our average is now $1.8 billion. On a monthly basis, in February we collected darn close to $2 million, as we did in January. So cash has been good. Our days cash on hand is now at 106 171. So now we are, as we were, as we closed 2015. Our average days is 156. We certainly don't think that's going to go down in the next few months as we're closing this year. So that's good. Okay, so here is our profit and loss. For the month, we had very good revenue. We're at 1.99 million, we're above budget. Our expenses were below budget. And our net, or our total gain here, 21,000, was 120,000 better than what we expected it would be. So for the month, we had a net gain of 130,000. For our year-to-date, then, we're at 168,000 net gain. That's 70,000, or 96,000 more than we anticipated it would be. And it is less than last year at this time by about $400,000, as we expected it. Our balance sheet for the current month is here. Our cash has gone up, not unexpectedly. Year over year, there's a good increase. And our accounts receivable is also up just a little bit, but I think that's kind of unavoidable in spite of all the cash we've collected. With the 2 big revenue months, you're going to have your air going up. So big revenue. Other than that, nothing that I thought was really. So then on to Goose Lake and Lakeview Gardens. Oh yeah, okay, right. Both sides. Questions on Lakeview?
You have a neat little summary, I think you call it an executive summary or something that you would be
Yep,
preparing.
yeah.
It would really be nice if we had something to compare that to in a prior year. Is that a real hard thing to do?
No, I can do that. Let me write that down. So on that executive summary page, have a prior year. Okay. You bet. All right. And as Jen pointed out, I did totally forget to ask for approval of the budget assumptions. We distributed them last time and this time, but last time they were on the agenda, so we couldn't ask for approval. So this time we can. So did you hand them out again? Oh, we didn't send them out again? Oh, I wonder if we should have.
I sent them just to Jane, because she hadn't received them.
Okay. I think we were kind of ready to approve them last time, but would you guys like to see new copies of them before?
Have you got them on the computer?
I don't. Or maybe do we? Possibly.
Right there.
Yeah, there you go. Okay, let's see. I'm trying to remember what was noteworthy. Okay, so we are anticipating doing a global charge master increase of 5%. I have been in the process of talking with all the managers, getting ready or creating their budgets. And they're all pretty okay with the 5% increase. Lab thinks that maybe that's a little bit too high. I think one of the things we'll do is put it all together. And like we said last year, if we could have that be less of an increase, that would be good. With pharmacy, looking at, I don't know, we're like 40 or 50% over budget on drug costs. We're gonna have to raise our prices on drug costs to try and keep up with that. But if we could maybe have a lesser increase, but we need to put our whole budget together and make sure and see how it works before we really settle on that, but we won't go more than 5%. Last year, we did have a 6% increase. And it does predominantly affect the 30% of the business that's commercial, because Medicare and Medicaid pay what they pay. We are anticipating expansion of specialty physician services, growth in patient volumes for California, for coming up from California. We are budgeting for DME for those costs next year. We are anticipating, we've already hired an LCSW, but we are anticipating adding a primary care physician as well as an FMP to our clinics here.
Remind me what else he has been
Um,
licensed.
Clinical social worker.
Okay, thank you.
I believe we've signed a contract with our OBGYN to expand services. So we've got at least 1 week a month, and maybe we'll have more. We are going to anticipate a somewhat increased reimbursement for Medicare based on the separation of our long-term care. We anticipate that Medicaid patients will, have some growth. Let's see. Taxes should be static, continuation grants. We are going to be negotiating with ONA, the nurses union, very shortly, so that will be prior to budgeting, so then we'll have a more concrete number for nursing to budget for. But at the time, we're kind of anticipating 2%. We are currently at 185 FTE, and we have budgeted for an additional 11 FTE. If the MAs will be hired, of course, if we hire one for the family physician, one for the FMP, so that would be contingent. We have already hired the 2 informatics people, a speech therapist. We are recruiting for that position, and of course that would bring revenue with it.
Is that going to be the shared one possibly with ESD?
We're interviewing that person on Saturday. And that would be shared with the school. And the school, whoever from the school representative will be involved in the interview process. So we're not sure if it's going to be a full-time FTE or half-time. It's hard to predict how much time each party will need. Sorry.
It's okay. So other than that, the increases are pretty marginal. Cardio rehab nurse and a little bit, we need some employee health and infection control with the loss of Helena for a while. And we've got 2 people working part-time that might add a day a week. Our benefit package, I mean, we're going to have to assume a small increase for health insurance next year, even though we have, by some wild luck, have not seen increases in health insurance.
One of your FTE issues, don't you need somebody for DME?
The DME guy was hired in this year, so you're right, that is an addition, though we kind of hired him this year, it's part-time. So we have Michael, who is bringing our DME up to speed and has been doing a lot of work on that. But we kind of anticipated that we would replace him with a part-time person later on. Because I don't know that, I'm not sure he wants to do this forever, but we'll cross that bridge when we come to it. If we're expecting materials and services to go up between 1.5% and 2%. We did talk with our pharmaceutical supplier, and they've already told us to expect at least a 6% increase in what they're charging now. So we will budget accordingly for that. Some of the plans that we've talked about, I mean, none of this is new to you. The space expansion and the debt we've talked about. And unknowns are kind of the same year after year. Changes in the industry, loss of employees, competitive factors. Questions?
Do we have a motion to approve the budget assumption?
We can take turns, Jane.
I will move to, since it's my turn,
Yeah.
to approve the budget assumptions as presented.
Second that.
Those in favor?
Aye.
Aye. Thank you.
Okay. So then, I don't want to touch that because I'll usually screw it up. Okay, so now, moving on to Goose Lake and Gardens. So Lakeview Gardens has kind of been holding steady. There's a slight increase in resident days from 620 to 617. That's still pretty good volume. Their revenue is here. The revenue went down just a touch. They're at 158,000, down from 165 last month. But they're above their monthly average of 150. So kind of steady, really, month to month here.
Roughly how many beds you've got filled?
23, 24.
Can stay around there, really. Profit and loss for this month, they had a profit of $14,000. They had good revenue, kind of average wages, benefits were down. There was a correction to accrued PTO that caused a negative number in there, so that brought that down. It was just a system kind of error correction. And then, of course, expenses were lower because we had taxes in the prior month. So we ended up with $14,000, but year to date, we lost $152,000. Last year, we ended at $151,000 loss. So kind of right where you expect them to be.
Is this on your new accounting system?
Oh, good question. We have started billing in PCC as of April 1st. So we are, and Melinda is pushing her side, so everybody is going to be in PCC for all of April. So,
Point click here is the PCC. That's the name of the software.
yeah, then you stop.
Sorry.
Balance sheet, location AR is at 330, and so kind of no changes here, as you expect. Very little going on in the page. Then, questions on Lakeview Gardens? Of course, you're welcome to call me anytime if you guys have questions based on what I send you. I'd be happy to look at it. So Goose Lake, their revenue was at $48,000 for the month. The good news is, as we talked about earlier, we're off hold with Medicare, so we should be able to start collecting money soon. Or we're dropping those bills, and Medicare pays pretty fast, so that should start coming in. We don't have an FMP in Alturas right now. We cannot achieve the revenue levels we need unless we have a job. Based on phone calls and word from the state of California, we're very close to getting the license for Tony, but you know what, you don't have it till you have it. So as soon as he gets his license, he will be practicing in California. So that would be good.
He is one of the contributing factors to why our volume in the clinics here in Lakeview were as high as they were. It was very, very good.
Yeah, people really like him, and he started seeing 15 to 20 people a day almost, within a few weeks of starting. So he seems really happy, and it's been a really great start, I think.
He's commuting now, is he? Does he live in Alturas?
Yeah, he lives in Alturas, so yes, he's been commuting, so he'll probably be glad to not have to do that anymore. Okay, so then for the month of February, we lost 6,000 in Goose Lake, and for the year, we lost 43,000. The balance sheet, no real changes. Naturally, AR is insanely high and will be until we start collecting, and Medicare is our major provider there, so the fact that we've been on hold for several months is is terrible. But they should pay very quickly, so mostly we just, we'll have our bill, the billing department is working very hard on getting those bills all pushed out to Medicare now. So they'll do the best they can to get that out. Any questions about Bruce Lake? Any questions about DME? We actually have made some really great progress and signs, we're working on contracts and looks like Michael is very excited about the things that he's accomplished. I won't say much about it, but already feels like he's going to find some super ways to save us money on oxygen. So I would say that even if DME doesn't make a ton of money, he's probably going to save enough money on oxygen costs to cover his own wages.
You're talking about the hospital's oxygen costs.
Yeah, so it's exciting. Anyways, it's infectious, I guess. This enthusiasm. All right, well then I'm done.
Thank you.
Thank you.
Let's see, sounds like Jane's up.
Yeah. So, in February, Charlie and I went to the, it's the American Hospital Association, is that correct? Rural conference in Phoenix. And it was mainly board members and administrators. There were some providers, not a lot. It was a really interesting conference. For me, I think I learned a lot, probably a lot of it because I'm a new board member. So there were a lot of stuff that was just, maybe some new board members that have been around for a while wouldn't have picked up quite so much, but it was very helpful. Some of the breakout groups were interesting to me, just to find out what other hospitals are doing around the nation, because it was nationwide. And also, it's always interesting to find out who calls themselves rural and who doesn't. To find a rural hospital and there's, in a town of 40 or 60,000 people, that's always interesting. But it was, I guess, one of the takeaways for me was the different ways that hospitals are, rural hospitals, some of them are still like we are, I guess you'd say a standalone hospital. Some of them are affiliated with larger hospitals. Some of them are associated kind of with the types of things that Charlie's working on with, to the south and to the north. And those things are just, I think kind of like us, they're just kind of getting started. I don't think there were any that were really going strong, were there?
Well, the way to describe that is those that are robust, and there are some, are driven by large hospitals creating feeder hospitals. So if you think of it as a hub and spoke, if you're a large hospital, what you want to have is you're the hub, and you want lots of spokes. Those are the places where it is very robust. Those areas where the kinds of arrangements that we work on, which are more equal to equal, building relationships, that's a little different. You don't see a lot of it.
Right. But there was interest,
A lot of interest.
and there were the board members I talked to in rural hospitals that had been like us, but now were affiliated with larger hospitals. None of them were very happy. They felt like they had lost their, what made them special and special to their communities. They were still there, so they were, but much more in an advisory capacity. So that was, and when you asked them what they would have done different, once it got to that point that they had to go to that affiliation, there really wasn't much they could do. They were kind of generally financially, they had to get there. I don't know that I would recommend that we go every year. I'm not sure. What did you think, Charlie?
That was the first time I've ever gone. Sometimes you could go to conferences every week. There's something, and a lot of it is kind of redundant. But for me, what I wanted, the value was to hear about the, amongst many things, one of the key things was to hear about the swing bed expansion program that Mayo Clinic made the presentation about, and talked about how is it working for them. As you know, I was involved in helping to get the legislature, and they did grant $10 million toward that amongst other projects. So we're going to see that happening over the next 3 years here in Oregon. So there was a fair number of Oregon hospitals that went specifically to hear more about that and hear the discussions. So is that something you want to regularly go? There is. I think it's real helpful for new board members, or if you haven't been to healthcare conferences, and that's something that it might be helpful for you, or you to go to if you wanted to do that. There's a conference in Minneapolis in June, I believe it is, that is put on by an auditing firm or accounting firm. And there are some specific conference issues that might be worth looking at. So you have to justify it, determine, is that conference worth going to? Not all of them have stuff that's worth doing, or that applies to us. I think it's, like you said, rural is very different from many people's standpoint, but what defines us is remote. So if we look at other remote, not just rural, but remote communities, then there are applicable comparisons. And often those are West state hospitals in the western states, Alaska, Montana, Nevada, those kinds of organizations. And so sometimes we can learn a lot. But Washington Hospital Association has a very good conference. Montana does. But not necessarily the American Hospital Association.
Definitely the difficulties in recruiting physicians is everybody nationwide. Yeah, that was, and nobody had I mean, there was one hospital that kind of had or one administrator that had a unique philosophy, and he actually knew Lakeview. He had worked in Oregon, if I remember correctly.
He had been a recruiter.
Yeah, he had been a recruiter, that's right, and then he went on to become an administrator.
On that philosophy?
Was that?
What was his philosophy?
Was it the zealot philosophy?
Well, kind of. What he looked for, his angle, and then he was in Oklahoma, panhandle of Oklahoma. And that's a pretty hard to recruit for a community, or that area, if you have ever been in the panhandle, or for that matter, in what used to be referred to as the Dust Bowl. He looked specifically for physicians that have a zealot or mission to go and serve the significantly underserved. So he found people that were either doing this because of religious reasons and wanted to, and say if they wanted to spend 3 years in Africa and come and work at this hospital. So his arrangement was if you worked for us for a year or two, we would give you the time to go to another place for a year, 6 months, but you could come back. So they looked for the missionary type, the zealot for serving significantly underserved people.
And he recruited groups of friends, like 4 friends that were
Some
went
were
through medical school together.
Right, they either gone to medical school, they had the similar religious motivations or service orientation. So he called them the zealots. That really were mission driven. a wonderful thing.
Yeah, it worked for them. It was something different. Anyway, I got a lot out of it, and I really appreciate the district sending me.
Thank you, and thank you for taking the time to go. That's an effort to do that. It's a big effort, and it certainly improves our board. Medical staff, I guess, Charlie, you're the doctor tonight.
But, we want to ensure that our physicians, as much as they would like to be here, are, if they're seeing patients, and I believe Dr. Hussey was covering the emergency room, so it was difficult for him to be here. At the last medical staff meeting, and I think we've sent out to you the two re-credentialing applications. One's for Dr. David Lee, of reappointment, and he is a courtesy staff teleradiology, and Jonathan Cole, also a teleradiology consultant. Medical staff recommend that you approve these reappointment applications.
So moved.
Second.
Those in favor?
Aye.
Aye, thank you. Deed to the town of Lakeview, we're giving something away.
We are. A small community, we want to keep everything as close to the best as we possibly can. As you recall, when we began down the path of establishing two locations for the three cottages, one of the requirements for the assisted living is that it could not be located adjacent to a hospital. So we came up with an option to have a plot of land between the hospital and the property of the assisted living. And we have a deed drawn up to give that plot of land to the town of Lakeview. We would maintain the plot and have mow the grass and maintain the shrubbery and the garden-like environment. So it is our recommendation that we created the deed, and Jim Lynch reviewed this with John Bogart as representing the town, and have come to an agreement on the deed itself. Do you have any comments you want to make on this?
No. Tell me again the size of the parcel, Charlie.
It meets exactly the size of a plot of land for a house. So the exact square footage.
Per cottage, you mean?
60,
Yes, it
three
is.
OL lots.
Pardon me?
3 OL lots.
I don't know, 3 OV lots.
75 by 120, I think.
135.
That-
The 135
Okay.
So that's what it is.
Okay.
So it met the town's requirements to have nothing less than that minimum requirement. It didn't exceed. And the requirement from federal government was that there could not be any, it could not be adjacent. So because it can't touch, and to the east of the property is the BLN property, so it didn't abut there, and on the west is homeowners. So it met the letter of the law. So I recommend that you approve the deed to transfer the property to the town.
So moved.
Second. Question?
Yeah, question. That ruling that we had to live with was, it was written so that the states could request a waiver to that. And Oregon had requested that that be dropped, and it had not been answered at the time we were looking at this. Do you know if it's ever been answered?
And what they anticipated is the answer would maybe come around 2020. Certainly after the election. But what we call the Department of Health, DHS, on a national basis. So it's not exactly Health and Human Services. This was described on a national basis. It really had greater impact on states that were in the Appalachian areas, whether it's Kentucky or Tennessee. And limited impact anyway.
We have a motion, those in favor?
Aye.
Aye.
Aye. Thank you.
Thank you.
Here now, I'll give a magic one.
It's What's that?
I'm sure the town will give it back.
I think so. Personnel, I guess, Charlie.
First off, I want to make sure that everyone has had a chance to meet Leslie, who's been our new HR director. Sorry to see Linda retire, but I'm happy for her ability to retire. And we're happy to have Leslie here as her replacement. A couple things that we need to do, and I've asked Leslie to, I'll do the first one, and then you can move on to the second. If you recall at the last board meeting, what we did was, with Linda's retirement, anytime there are any pension plan changes, it needed to be signed either by a representative of the hospital, personnel, was either Linda or myself. What we did was, you follow what I'm saying?
I don't think you guys finished the motion on the deed signing.
We did.
Yeah, you did, okay. I guess
We approved it.
I just wrote down that you guys did it, but I didn't think there was a vote on it.
Yeah, we're voting.
Unanimous.
Sorry.
No problem. So what you did at the last board meeting was you appointed Holly Fairbanks. Fairbanks. Excuse me. Sorry about that.
Could have been Anchorage, but it's not.
I was thinking about Anchorage when I was saying.
He was just testing you.
Every now and again, I just have
Didn't work, did it?
No.
things that don't
You
always
passed.
line. So Holly and I are right now the designated individuals that sign up. Anytime an employee wants to add or change or borrow from their pension plan. That's usually the issues that are involved in this. What I would recommend that we do is we add Leslie's name to that list. So I would recommend that we do.
So move.
Second.
Those in favor?
Aye.
Aye. Unanimous. Thank you.
Have you noticed how efficient we are?
Yes,
Yeah.
Too efficient.
I feel like I'm spoiled.
Keep
on my
up with the
first
day.
meeting.
So Leslie, if you move on to the next item.
Yeah. All right, so with the education, training, and travel request expense, what we're trying to do is we've just added a few things to a policy to make it more efficient. We would like the travel requests to go through the executive assistant, who is Jen. So when we have individuals that are going out of town, usually for trainings, we would like them to go through Jen to book those trainings. And then she would obviously cover the costs and find the most equitable place of lodging. So we've added that to the policy. Did you guys get copies, or Jen?
Yes.
Okay.
We did add those two areas in the bold after that went out, and it was late enough in the day that it didn't get
Oh.
sent out, so you might just want to read those two
Oh, okay.
bold
All right.
areas.
So that was added, was to have it to go through the executive assistant because it's more efficient and it's much more cost effective. And then the second thing that we added were the advances that they will receive in advance in their last paycheck. For ONA, it's 85%, for the Teamsters, it's 75%, it's contractual. And that is for anticipated expenses that are incurred. So that was added to the policy. And then we've had, from discussions, I'm very new, this is my first week solo, there have been some challenges in getting folks to turn back their receipts in, because we need original receipts when they're coming back from their travel. And they've taken up to 6 months to return that. So in order to be more effective and more efficient for our accounts payable department, I have asked that it be 30 days. And I think that's more than ample time to turn in your receipts. And under the ONA contract, I believe it's the next day. No? Is that, no? Jen, help me out here.
Yeah, we read the contract.
But that's not necessarily been enforced. So that was added. And then as well as original receipts. And the reason for that is that the hospital does not reimburse any alcoholic beverages. So when you get your billing on your statement, it just gives you a summary total. It doesn't give you an itemized receipt. So we are requesting original receipts in order for them to receive their reimbursements. And I believe that is it, other than if we have given them an advancement and there's an overpayment and no receipts are provided, that we have the authority to deduct that from the following in service. So if they take another training, we say, well, we've already given you money and this time is on you.
Now, what happens if Jen's not available?
Oh, then they come talk to me.
Okay.
We have backup.
Yeah.
So Jen, then in reality, when someone comes, they want to stay one place and you find something that's less, how is that determined where they stay? I mean, it might be $5 or $10 difference, or...
It kind of depends on where they're staying, where they're going. Sometimes it's more cost effective, like for instance, for them to stay at the hotel where the training's being held. For instance, San Diego, if it's being held at a hotel on the water and the nearest hotel is probably 15 miles away, it's not cost effective to put them somewhere else. Most times people don't really say, oh, I have to stay at this place. They're pretty, wherever they get booked, as long as it's fairly close, most people don't tend to have a problem.
So it's negotiable.
Got it.
What we also sometimes do is if the conference or the meeting is held at a very nice hotel, but right next door is a more affordable place.
Look,
That's nice.
Well, we try not to put it under the rule that says, but we try to be as efficient as we can. And what we have done, if you recall, we've added credit cards. So now we have many credit cards that people can use. Not all credit cards are the same. Some are only limited to what they can buy. And as such, the credit card that Jen uses when she places those orders, although she's the only one that has, besides mine and Cheryl's, I guess, that can book cars or hotels or airlines. So that's how we restrict that.
As I recall, it was $30 maximum for meals a day.
Right.
Yes, not including those alcoholic beverages.
What about the tip?
Not including the gratuity either.
And
Nope.
probably our per diem money is a little bit low, especially.
I mean, I just got back from 2 weeks being out and about, and when you're in Lakeview, it's not the real world as far as that.
And so
So anyway, I just tossed that out, maybe it's
we
right.
can't really expect that employees, when they're on a trip, can only eat at fast food restaurants or have to use their own money. So we do look at that,
Okay.
try to adjust it.
And I'll play devil's advocate. You have to eat, and you're going to pay to eat something while you're at home. So if you have to help contribute a little bit, and I am being devil's advocate, it might be above that $30. So there you go. That's just my input. Because I want to make a great impression. First night.
Sending you with
Yeah,
a peanut butter sandwich.
I take my own.
Want to keep you healthy.
All right, I'm gonna beat you guys to it. I'm gonna make the motion
Oh!
to approve.
Well,
Stay with us, Dave. Where's
I'll second it.
Second, those in favor?
Fine.
Aye.
Thank you.
All right, the next one is fairly simple. It sounds confusing. I did talk to our wonderful Affleck representative, Kelly, this afternoon for clarification. What this is that there has been, I don't know, Washington Federal bought out the local bank. So this is about us opening a new account. And so we need to have someone be the signature to say, our payroll department can deposit money in an account, and then Affleck owns WageWorks. WageWorks is our third-party vendor who deals with our flexible spending account, the S-125. So that's the reimbursement for pre-tax federal dollars for medical. which employees contribute to if they so choose. It's a voluntary program. So what we need to do is open an account with federal that says, yes, we're going to deposit our payroll monies into this account, and WageWorks has the authority to withdraw it in order to reimburse our employees. So it's really only a one-time signature opening the account is what we need. And there's a whole list of folks on there that have the authority to open this account, but when push comes to shove, it will most likely be Charlie who needs to put his signature on having an account with Washington Federal. And
So
that's,
the money that goes in there is the money they take out of people's pay.
yes,
Right.
thank you, thank you. So there's a payroll deduction, and that is put into a fund, which is then dispersed to WageWorks.
People spend.
Yes.
No, I'm all buzzed up.
Sorry.
Mike,
I was hoping that would be easy.
You want to do this or you want to?
Yeah.
Go ahead, Cheryl.
You're about
the
2 or
banker.
3 behind.
You're the banker.
I can draw a
Let me
diagram.
stop you before you get too far
Yeah.
down the road. I think they actually want a corporate or a resolution in addition to authorizing the signers.
It's 2016-1.
Yeah, so it might be good to, have you guys seen that?
Yeah.
Okay.
I sent it out, yeah.
Yeah.
So the motion would be a motion to approve resolution 2016-1.
Yes.
Was that a motion?
That was a motion.
Oh, okay. I'll second it, Cheryl. There you go. Those in favor?
Aye.
Aye.
Aye, thank you, it's approved. Lakeview Gardens, Charlie, get us straightened out here.
Okay. I sent out to you the revised, or the addendum to the joint contract with the guaranteed maximum price. It's different than what was originally estimated. And what we need to do is have you approve that addendum. Jim had said that I could go ahead and sign that because it was an addendum to the contract, but I want you to have that information. We've done a couple things with that to verify if in fact that is acceptable. Washington Federal wanted to make sure before they would issue the bond that they had an outside independent organization look at those costs. And we're paying for an outside consultant to look at the costs based on what the plans were, and they agreed. The company's called Adel Construction, out of.
That's in your flush. right?
Not in
No.
A-double-E, it's two L's, A-D-E-L-L, construction. And he also agreed that pricing was justified.
But Charlie, that addendum is about the number we were talking about earlier, nothing huge has changed.
That's correct.
Yeah.
So one of the questions that Chuck had, he said it looks a little different, 8,139,000 versus 8,039,000. There's still some variables. And the reason for that is at the time of getting the guaranteed maximum price. So there's a sequence of things we need to do as part of this project. Number one, as we went through the list of that you've seen, all the different items, the items that were below this price of February 19th were items that may or may not be something we want to do. So we looked at, could we do the project without using geothermal? Could we save money? And so at all those items, we went item by item, trying to figure out, could we get away with this, could we not? There were a couple of items still left at the time of signing the guaranteed maximum price. So that was the med gas and the roofs, and the other was the types of plumbing fixtures. They could not get, they being Adroit, could not get absolute firm from what was bid by the plumbing contractor, some differences of the kinds of plumbing, not appliances, but connections and fittings and that sort of thing. And it's significant dollars. So that's what he said is if we leave it in there, we're not going to pay a fee on it, we don't have to spend that money. But if we're going to go below that, then we would have to have a change order to go above it. And so that's the reason why picking that number. We want to limit as much as we possibly can, change orders during the construction project. Because change orders are expensive to do, and if you're not careful, you can spend a lot more money than you expect in that process.
The GMP contract with the drawing he signed was for $8,037,239. And then there was another document that you sent to us that had that up to $8,180 something.
It is the lower number, that's right. Okay?
So, being that that's done, do you need another, do you need a resolution?
What Jim recommended is that you accept the addendum to the agreement.
So moved.
Second.
Those in favor?
Aye.
Right, thank you, Gerald. We're done. And we're free. Nursing report, Teresa.
Well, yes, just a couple little updates for you from our corner of the world. So just to let you know, the infusion therapy service that we engaged to help us both with the scheduling and billing piece of our infusion patients as well as chemotherapy patients. I'm actually very impressed with them. They've done a remarkable job.
That's the Dallas or?
Yes.
Yeah, I'm surprised at how well they've been doing that. Their person that we deal with on a daily basis is extremely efficient and reliable. And we're still working through some issues, which is to be expected, I think, with a change in culture. The biggest issue is patients who come into the emergency room and then need to return for outpatient antibiotic therapy. That's a change for us to remember that we have to call a company from outside and make sure that all the prior authorizations are done. So we're still working out a few bugs in that kind of a scenario. But for the most part, he has continued to increase our infusion patients. We've had new patients coming on board weekly. So the staff the workload has increased, but it's doing really well. And I just wanted you to know that. It's doing so well, in fact, that coupled with the fact that we've had several issues with really high census in acute, that I'm kind of recommending that we may have to look outside of acute for that housing of that room, because that's an acute care room. So when we need to put patients, when we're bulging with patients on acute, we looked longingly at being able to put them in that room, and we haven't been able to. So I'm just kind of introducing that idea. But I wanted to report that it's going really well. And then also, hopefully you'll read about this in the paper soon, but we did start newborn hearing screening on our babies before they leave the hospital. They'll now be screened using a nationally recognized guidelines as well as a piece of equipment. So they'll go through the first phase of that screening here before they leave. It had been done in our county by public health, but the problem was they didn't have a captive audience the way we do, so they were having more trouble meeting up with people outside of the hospital, whereas it's a little harder for them to escape us before they go out the door. So we've gotten that started and done our first couple screenings already. So that's gone well. As well as, I'm happy to report that Megan Cruz, who's taken over the OB lead position, is doing a fabulous job. She's achieved her finished her class on lactation consultation, so she started doing that, as well as teaching the prenatal classes. So if you happen to go into the cafeteria right now, she has 6 couples starting the new program. So that's going really well too. So she's very enthusiastic and very passionate about her the pregnant patient, the newborn babies, as well as about breastfeeding. So that's going well too. So I just wanted to let you know about that little piece tonight.
I noticed in one of our reports that there was a request for converting another room for taking care of the nursery people. It wasn't ever, the job wasn't ever done, but it was in, what do you call that?
The birthing suite,
What's that?
the birthing suites that we
A
have.
birthing suite, yeah.
Oh,
Converting
yeah,
the
no,
room.
we did, we had that in the capital budget.
The capital budget, that's.
Right, for this year, and believe it or not, that was just finished today.
Oh,
So funny you should ask. It was cabinetry, it wasn't a very big change in the room, but we also added an additional fetal heart monitor and a birthing cart. So now the room that was originally designated as kind of an antepartum, postpartum room, it's 203, it's the furthest room into the back. That room was never intended to be a birthing room, but now it's set up so that it can be. We've had a few times when we really needed to use that room. We definitely needed it set up better. Even if we don't deliver in that room, we can do other things in there that we weren't able to do. So that was just finished.
can we still use it for normal acute care?
No, it's in the OB area.
Oh, okay.
So it's the 3rd room in the OB area that was never, originally, when we did the construction, we didn't build it as a labor and delivery room. It was a semi-private room. And we intended to use it for C-sections or patients maybe that came in prior to delivery that just needed to be monitored. But we needed to be a little more flexible. So last year, the staff group that we call the OB committee had recommended that we convert that room. And like I said, it just was done today.
Sure.
So that is done.
Thank you. Employee recognition.
As always, it's a great pleasure because we have so many people that are exceptional and work hard to try and figure out who would be the best one. So this time I'd like to talk about someone who is dedicated to the community, exceptional, ranging from support of the correctional facility, so doing a lot of things out in the community. This individual's church, city, fairgrounds, just never stops outside of the hospital. Very, very much a strong supporter. Most recently was specifically noted by one of our visiting physicians when if some of the departments are on call, but they don't actually, our department's not open. Department members have to come in and provide service. And this individual was exceptional, with coming in pleasant, not always at easy hours. We constantly get thank you notes from patients on how well this person works. Vicki Hansen, radiologist. Yeah, so just really
Good
exciting.
choice.
Yeah.
She's headed for Mexico tomorrow. True story.
One of the things that she did that was very, very thoughtful was created a going away present for Linda Michelson. All employees, many employees got to write on the tags, and she glued them onto a suitcase. That's what it's called, decoupage. And it was just, everyone really thoroughly enjoyed it, and Linda, of course,
Oh, but can I tell the best part of it? When she had the suitcase, she said, you know, it'd be really great if it was full of money. And she opens it up, and it was full of money. With dollar bills. And Melinda just got the best picture of her throwing her head back laughing. I mean, it was wonderful.
Did you run the budget?
No, they brought me
Actually,
in.
those were all done by
Donation.
Donation.
CEO report.
Yeah, we have lots, this has been an active month, and there's a lot going on. When we brought on an extra person in our plant management, Shay Robinson, if you recall, one of the great things was that he was readily available when, most recently, our freezer died. And he kept it alive, and then we just now, this is the walk-in freezer that was originally part of the original hospital. And it could not be held together any longer, so we, guys had to take it apart, build it. We kept a lot of our food in the lockers, thankfully, we have that available. And so we got that up and running, and he kept that working. We had this past week, a break in our geothermal system. The pipe, not far from the home, had a leak in it. We had to fix it. We got it fixed, but just today, problems with soil getting into our filtering system. So we just resolved that today. But having the staff ready and available to fix that was one of the first times we actually used propane. Hot water in quite some time, so we're glad to have that. I was able to go a month ago to the new medical school in Lebanon, which is for osteopathic physicians. They started up in 2009, and they currently have over 100 residents and fellows in the program. Significant increase. Most of which are staying in the Lebanon area and Albany in the area that supports the health system, Samaritan system. But more and more physicians will be coming outside. And so we talked about how this would be a great place for family doctors to consider. And so making inroads, trying to find opportunities for us. As Cheryl said, I'm very pleased to say that we have hired Karen Jones, who's a licensed clinical social worker. She will begin on the 18th. Her last day, I think, is Friday at the Lake County Mental Health Department. She will be included in our clinic. So one of the things that is really a big change in how clinics are functioning is to add more and more other types of services, not just primary care. If you embed mental health, that helps take away some of the stigma of patients going to see somebody in mental health services. It will also really help our primary care physicians who have patients that need to be seen right then. So that it's going to be a very exciting addition for us. We are interviewing several people, nurse practitioners and physicians, to see if we can add either here or in our tourist clinic. We have an interview set up in the next couple of weeks for this. So hopefully we'll find somebody that we think will work. Some of which may be in the mental health services. One of the reasons why that's really important is to create what's called a patient-centered primary care home. You may have heard me talk about this in the past, and that's where you transition from just a physician's office to being able to track more of the population of the health of the patients, look more at how well are you managing all of your diabetic patients, or your pulmonary patients, or chronic obstructive COPD patients, that kind of thing. So we have been actively working on that, and our plan is, as That's one of the reasons we have the e-clinical system that'll enable us to do that. And it looks like we will begin more actively that process as of May 1st. We have to be able to use the system, we have to have, I mean, there's just so many features that we will be adding to it. One of which is, as an example, we will have after-hours call number. Right now, if someone wants to get a hold of our clinic, they call after closing, our telephone number says, call emergency room, or we're not answering the phone. We'll have an answering service. That might help reduce our emergency room visits. Because some of those emergency room visits could be managed appropriately in the clinic setting. So that will also help manage our health, the health of our population in a more cost-effective fashion. That goes in line with what the CCO business is all about. And when we think about how our CCO is doing, we'll talk about that in a second, but that's great. There are targets that we want to meet because there's economic incentives to meet those. Being a patient-centered primary care home provides us more. There's a lot more work, but there's more money to help pay for that. I have out here in front some RFPs or requests for proposals. This is for doing the clinic remodel. We talked about this. The time we received 4 proposals: CTA from Boise, Idaho, CZS Engineering from Grants Pass, Steel Associates Architects from Bend, and Pinnacle Architecture from Bend. All have submitted applications and they met the requirements. We will be having some, we'll see the schedule. If you would like to be involved in the selection process, it will give you an opportunity to participate. We'll look to start interviews in about 10 days, 10 to 15 days. So the goal is to have construction, the design completed by September, and have construction documents by September 15th this year. So we'll have an idea of what the cost would be and what would this look like. Physicians, as you've heard, are very interested in knowing what we want to do. Any questions about this that I can answer? You all have copies of these. From a DMV, now let me talk about the CCO. I was at the CCO board meeting on Monday in Pendleton, and there are several things that you probably need to know. If you recall, back in December, there was concern that Moda Health had been deemed to be possibly not fiscally sound to handle the business with a lot of questions. And Moda Health is a 25% owner in the Eastern Oregon CCO, as is Kobe Health, and then several hospitals and partners. It was found that Moda met the requirements, everything was fine with them, they went through that process. But I think it's important for you to know how well the Eastern Oregon CCO is doing, because that impacts us, because we are at risk for some of that business. In 2015, the budget was that we would have about $255 million in premium dollars to handle about 50,000 subscribers. Those are the Medicaid recipients in all of Eastern Oregon. And that after all expenses, we would see about $1 million bottom line. The owners, keep in mind, are 4 hospitals in Eastern Oregon. We had the opportunity to be an owner. We chose not to because we represent about 3.5% of the total population. It doesn't really make a lot of sense for us to take risk for that business. Actually, what ended up happening was, because of the way, and this is what got Moda into this problem that they had, is the actual rates for the premiums were not established for 2015. until just about a month ago. So it's very hard, if you know, in the insurance business, premium is the revenue that you have coming in. You plan about 85% is going to be expenses. The other 15% is administration and profit, that kind of thing. If you don't know what your income is going to be, it's hard to predict how you're going to do. As it turns out, Eastern Oregon CCO had $286 million, almost $287 million in premium dollars. As a consequence, at a $15,600,000 profit, or profit from the income from the business. And a very good year. Where the budget for next year is premium would be about the same, $285 million. And income from operations of just under $2 million, which would be much more in line to what it should. So we had a very strong year. It didn't help us in Lake County significantly, but the other part about the insurance business is, well, one year may be good, next year may not. So they have to maintain a fair amount of reserves and continue to do that.
And I think it's in there somewhere, in that review, it looked like there was a $4 million change in administrative profitability or payment one year, and then it's going back to what it was before, like a $4 million
Well,
change, but it was tied to something, I didn't understand. It's tied to something, I don't know.
there are several parts of this that make it hard to exactly explain. You have to really understand the insurance business, understand the risk business, and understand how the state sets the premium. So the state gets the premium dollars in part from what the feds allow. So if the rate increase was going to be too high, the federal government didn't allow it. So in fact, our CMS didn't allow it. So the state, since it's a matching plan, that's how that number varies. The $4 million that may be referenced to is called IBNR. Now, IBNR is called, what that means is called incurred but not reported. This is a hard part about risk contracts. What that means is if you're looking at a financial period, if patients have gone to see a doctor the day before you did your report, you know that they have been to see a doctor or been into a hospital, and then you know they got services, but you haven't gotten the bill. So the service has incurred, but they haven't reported, so you don't know what it is. The only way you can estimate that is based on the track record in the past, and then you use some modeling tools. That's the IBNR, and it can fluctuate. Generally, it doesn't fluctuate widely, but it is hard to predict sometimes, especially in a very new population of patients like this. And what made this new is while the Affordable Care, or the CCOs took on the Medicaid population, the expansion population, that's where it went from 100%, 115% of poverty to 200% of poverty. That's included in this. That population is older, hasn't been seen by practitioners, and so there's much greater unpredictability in that population. Therefore, costs are harder to estimate. That's where you see that variance. Over time, you'll have a better idea of how that works. And that's why in 2016, the budget estimates are much more in line with what you would expect. Now, the value that remains to us is in the risk pool funds. So when we get paid to see patients both in our clinic as well as in the hospital, if we charge $100 and they say we're going to pay you $95 for whatever service we deliver, they hold back 10%, $9.50, and say we're going to put that into a pool and hold it for you. If the business does well, we'll give you that money back and some. If the business doesn't do well, you don't get that $9.50, that withhold. So when the CCO does well, we get our money back and then some. And they're looking to have, the risk pool dollars are going to be significant, and that'll be dispersed. We got monies back last year, if you recall, it was about $50,000. So it's not exactly clear yet what number we will get, but it's looking very positive for us. And that we will finally get to at the, probably May, it will be determined. And so what you do is when the year ended, if the year ended in December, you wait 90 days so that that IBNR is pretty well defined. Because you should have gotten all claims and processed within that 90 days. Does that make sense?
Charlie, the paperwork you sent us, I think it netted out about 1,500 in our district of Medicare, Medicaid.
In Lake County.
Lake
Not
County,
just
so
our
that was
district.
1,700 in Lake County and 300 in northern Lake.
That's right.
Okay.
That's right.
Are we getting paid in per capita, or are we just getting paid a cost basis?
We get paid in two different, now it's a combination. We get paid a per diem for the clinic. We get paid a percentage of our charges for the hospital and outpatient business. And then because it's cost-based for Medicaid, when we do our cost report, then there's a truing up at the end of that by the CCO, because we're a critical access hospital, and we get paid cost-based. So the hospital, we get paid the per diem, which is an estimate of what they think it will be, and then it's trued up at the end of the year. The clinic, we get paid a per diem, and our per capita is really,
So when the patient comes in and out, get paid so much per patient.
and then because it's a rural health clinic, we get the enhanced payments from the cost report. Okay, so one of the reasons why it was so important a year and a half ago that we talk about becoming a rural health clinic is the enhanced payment. And that has a significant increase for us, and very, very important for us to do. So we don't yet know what that enhanced payment will be until we go through the cost report. And then that's all part of that rural health clinic. And if you recall, we talked about doing an interim cost report. And we did an interim cost report last year because of the change of Lakeview Gardens. We do an interim cost report this year, this spring, because of the rural health clinic addition, to capitalize on increased reimbursement. And we'll be doing that just as quickly as we are able to. Does that answer how that works? Okay. I don't mean to get too close to the weeds, but it's important to understand that. Do you have any other questions about the CCO? We have some metrics that we need to work with our doctors on to try to improve. One of the things that's happening with the CCO is the state has said, we want you to do more preventative services. And in year one, 2013, it was $1 million was at risk. If you met the metrics, we got $1 million for the CCO. And we came really close. I think we met 12 or 13 metrics. Then the next year, 2014, went up to $3 million. Last year was $7 million. 2016, it's $15 million. What they're doing is they're increasing the incentive rules and reducing the payments to push us to reach those incentives. And much of those incentives are for population health, focusing on preventable services, mammograms, managing your population's diabetic issues, and all different things that we're working. And that's one of the big focuses that the CHIP program is working to address, as well as in our country. Okay. Lakeview Gardens. Larry Coulter is the administrator in training retired. He will start on April 20th. That was last week. He had to go to a training to make sure that I was competent to administer the training program. So it's about a 6-month program, and he'll start. So you'll see him coming to board meetings. He'll spend time different departments, all different things to learn about the functioning of the long-term care facility, as well as helping Belinda once we start the construction project. We are, I think I sent you a copy of our certificate of need that you received. We like the requirements that they put on it. So we'll check with you with that. We did get that certificate of need. We did get a response back from the state. They are now reviewing our application. If you recall, we have the certificate of need, we have the state planning department to review it, as well as the county planning. County planning is reviewing. We haven't found any problems yet. We'll see how that goes. We're addressing the issues that the state planning department has raised. Most are related to waivers. If you recall, we talked about, as part of this small house concept, for example, the OAR, the rules that define how we build a long-term care facility, require that you have a nurse's station. As part of a small house, you don't have a nurse's station. You have to have a waiver from that rule to have a nurse's station. So there are multiple things, and they've picked out a couple things that they wanted additional information. So we're moving through that process. One thing that we need to decide on is, do you want to wait before we start breaking ground and getting the soil ready to move for not actually pouring concrete? We want to start that before we've gotten the planning department approved. The issues are pretty nominal, or do you want to wait? That's a function of how quickly do we start mobilizing the construction.
What time period would you be talking about, in your opinion?
I tried to get an answer today to answer that question. How quickly will both the planning department and the state have an answer? It may be within a couple of weeks. I don't think, I mean, when I look at the kinds of issues they were talking about, they're not significant. So, but if we're going to start fairly soon, we need to plan our groundbreaking, plan all of the other components that go into starting this project.
What would be your recommendation?
I recommend that we get started as quick as we can. And what I could do is try to get an answer quicker from the state where they think they are, what their timeline would be, and then get back. Does that seem reasonable? I mean, I don't want to have us start actually building something, but it'll take them a couple of weeks just to bring in, take off the topsoil and compact it and put in the sewer lines and that.
There's a lot of gravel to put in too, a lot of crushed gravel.
And so when they put that in, they want to be able to take the topsoil off and start compacting it, and compact it, and test it. It's a couple of weeks of work to do.
If you haven't done that job?
Well, of course, I'm ready to go, but
It's light at 7. Tomorrow. Sorry.
Do I hear that you would be okay with us?
I will be up, but we'll keep it quiet, would you?
just, yeah, don't wake up Carol. You know, as long as you don't see that there's going to be a huge change in the plans, I have no reason not to get with it.
I don't see any of the changes impacting prepping the soil and prepping the space.
Right.
I mean, that's the reality of what I'm saying. So if that's the case, then we'll get working on groundbreaking and moving forward.
What's the status of the bank as far as granting the
Well,
loan?
that brings us to the next issue. And,
Got paid for it.
We have provided, they needed to have a couple of things. They needed to see the guaranteed maximum price. They needed to have the response back from the independent consulting firm determining if the cost of the project could be done within the timeline and the costs estimated by, or guaranteed by a majority. That came back. So then the next part is in talking with Washington Federal. We talked about, we've got this project, but we also have the possibility of doing the clinic and the possibility of any other projects. I said, you know, I think that it's probably prudent for you to consider getting some advice, other than legal advice, on what is the best way to manage your cash and your borrowing. And so they gave us, recommended 3 different firms that we talked to. 2 are very large firms. If you were in the business, you know the names. One is Kaufman Hall, which is a big company that does financial advising. Another is Piper Jaffe, and the third is a company called Blue Rose Financial. All would meet according to Ann Sherman, who is our bond counsel, that helped us through the getting the approved bonds and making sure that they met the requirements as a municipal organization. Her concern was whoever we would select, should we do this, they need to be a licensed municipal advisor. And all 3 companies meet those criteria. What we were advised is, because of the Dodd-Frank rules that were passed 2 years ago, banks can no longer advise us on the rights of what kind of loans that we get into, or bonds. So it really is pushing us. When we ask them for advice, as you know, we have a covenant that we can't get less than 100 days of cash on hand. How much cash should we have? How much should we borrow? I'm not sure that, no matter how much you think I know, I'm not competent to know it. And it's not fair for us to demand that Cheryl become an expert on knowing our restrictions. So as we've talked to these firms, I think it's become apparent to me, and I believe that Cheryl would agree with me, that getting advice, that's not legal advice, these are financial advisors that advise us and you on how do we structure the work that we do, and how do we make sure our covenants work. One of the firms said that just by banks knowing that you have an advisor, oftentimes causes their proposal to become much more aggressive in and of itself. So they're feeling, and one company that we talked to mostly and feel fairly good about. We've had some experience with some of the bigger firms where we think we're getting really good advice. Sometimes we don't always get timely advice. It isn't quite as appropriate for us. So we're kind of leaning toward a smaller firm. Is that they've talked about how it would be well worth our time, but if they could save us 10 basis points, their fees would easily be saved over the course of any kind of work. This company, Blue Rose, that we talked to the most, and we feel pretty good about it, they would offer a 2-tiered financing process. We pay them a monthly retainer to provide us this advice. And then every time we do a bond, they would spend more time than we would pay a higher amount. And getting back to what Washington Federal said is, we're okay with the current bond at $5 million. But if you're looking to do additional financing, you need to get some more timely and more succinct advice. And we recommend that you get something, rather than asking Washington Federal to tell us how we should structure that, if you need advice on it.
What you call a bond could be just a loan. Right?
So a bond for a municipal organization like this is a loan. It's essentially, they're synonymous.
Okay.
We have to get approval from the voting district. We have to go through all the appropriate process. It has to be structured to meet all the municipal restrictions that we have. how we use the funds, how we don't use the funds, all those kind of factors. And that's what we hired. We hired Tom Contorp to represent us in reviewing our side of the agreement. The bank hired another firm to review from their standpoint. And then we hired Hawkins, which was in Sherman, to review it from a bond counsel standpoint. So there were many, many attorneys involved in it. So it was an expensive adventure. But we did all the right things.
Would this firm take away any of those services?
What they would do is they would act as our financial advisors, not legal advisors. They would help structure the deal, give that to the attorneys, who would then structure it to meet our needs. That's really the bottom line.
Gerald, you're the old banker.
I can see from the standpoint that having someone like that is going to make financial institutions so much more comfortable.
But it also,
That aspect of it is worth something. I don't know how you put a dollar amount on that. And I guess if you want the type of advice that we're actually looking for, Chuck, these are places that we need to go. I mean, it's expensive.
but if they could save us, those basis points, it's
Sure,
money
that's their
well spent.
market employee.
Do you think that that's a reasonable expectation?
Oh, I do, yeah, yeah.
So-
I mean, they wouldn't be in business if they couldn't provide those type of services for those people, monetarily stated money.
He gave me an example, the fellow I talked to, that was the sort of the key guy. We talked to both the principal and the person that actually had been recommended to talk to. He said, let me give you an example of what we just did. We just did for a university in a different state. They were refinancing some of their bond debt, and about the same size as what we did last fall. They did it in 2 months and saved the university significant money. He said that's moving things right along. If you recall, it took us almost 5 months to get our process through. Now granted, we use that to our benefit because the price went down. But in a volatile environment, you don't know. We've been very blessed that the Fed has not raised prices. And so bond rates are actually better right now.
Someday, that's going to change.
Someday that's going to
Yeah.
change. But I think that it is a prudent position for us to take. And I would recommend that, I mean, it's being recommended to us by Washington Federal that they don't feel comfortable telling us how we should structure any kind of bonds going forward. Or how we use our cash, because if we have $5 million in the bond, we have a $3 million shortfall on that. We haven't been guaranteed a grant from Weinberg. It's still pending. We are hoping we're going to get that. We do have a fair amount of money that the district is going to put up, both from grant that we have, as well as from district funds. We need to make sure that we're doing the most prudent thing.
That's the issue that I don't think any of us are qualified.
So what I would like to do is...
Charlie?
Yes, sir.
And will Washington Federal give you any feedback when you talk about the different entities that you're looking at? That yes, we've done business with them and that's worked, or?
What Washington Federal representative, his name is James Coles, what James said, and Leanne has been involved in this conversation. What he said is it's against the law for me to recommend a firm. Secondly, I can't even recommend any of these financing arrangements because of Dodd-Frank and other issues. What he said is these are firms that we have used, and they're all good firms. So we interviewed to the best of our ability. I would like to finish our discussions, we still have some negotiations. It's probably looking at a cost that could be for doing a bond deal like if we're going to do an additional, I think we are going to do an additional financing for this. It may cost us maybe $50,000 in advice. Don't know exactly, but I ballpark that amount. Maybe less, depending on how well we can negotiate. But keep in mind, we spent over $100,000 just in fees to do the bonds. So no matter what you do, you can't be shy in this process. It is expensive.
They won't be able to, they can't give you an idea of how many basis points that would be approved in their offer.
That would be my answer. I mean, if they told me that they would, if they told me that they could do this, then what they're really saying is I could probably do 50% or 15% better. But I tell you better than what I think I can do and be on the conservative side, now I'm locked into getting a lesser rate. If they do it better than that, they'll look like heroes. So I'm not sure.
No, I'm talking about Washington Federal, but I can't give you any idea.
And what they said is Washington Federal told us they did a great job. Could we have gotten a better deal? They were pretty quick to give us that deal. Anytime anybody's quick to do something, I always wonder how much we left on the table. And I can't answer that.
Do you need a motion to go forward with this?
Okay.
If you're going to go forward with it,
Yes, I do. I would like to have a
you
motion.
got to know the price.
Well, because I'm negotiating the price. And I don't think it would be more. I'm pretty confident it will be less than that, but I can't be exact.
Do we want to wait till the next board meeting or not?
I
I don't want to hold up on our funding.
How about that, I report to you what the price is and I hit the best price I can. Because I don't think we're going to, if we're only going to deal with it on a price basis, then the cheapest price I get, not so that's the price. We're still trying to determine who's the best advisor. We didn't have all the answers before this board meeting, but I think it's prudent to move forward with selecting an advisor. I can get you the price as soon as I can. But I'd like to negotiate an agreement.
I would move that we give Charlie the authority to go ahead and negotiate an agreement not to exceed $50,000.
Okay, I was hoping that we would have a not to exceed. I'd second that.
Those in favor?
Aye.
Aye.
Aye. Thank you.
I also would not let them know that number.
No.
Or amazingly, you get that number right on the
It's
head.
going to be in the minutes and on the tape.
Well, not everybody watches. So I'm hoping that they won't do that. JPA, we are progressing pretty well with
That probably wasn't on the agenda.
so that's in my CEO report. Is that okay?
For now.
Okay.
I think you're right.
Pardon?
I think so.
It's our normal process.
Yeah.
Okay. In our discussions for, we actually are now calling them JPIA California and JPA Oregon because they are progressing in both directions. And that, with both parties, we're looking right now, there's a grant opportunity for us, the 4 hospitals in Oregon, us, John Day, Burns, which is Harmony District Hospital, Pioneer Hospital, to get a grant to work together. And right now, we're targeting to do a lean project. That would be a great way for us to begin working together.
What do you call it?
It's called lean. So lean is the engineering concepts that, as an engineer, I'm sure you've been involved with in the past, to look at, take everything down to its core. You look at it from a manufacturing standpoint. We've done several lean projects within the district, but this is about bringing lean to frontline staff. And the kinds of projects we've looked at have been starting out looking at readmissions to the hospital or streamlining our admission process. We look at ways to improve between the clinic and the hospital when the orders are placed. I mean, there's a lot of ways that we can improve the process for patients so that they don't have to keep waiting or find bottlenecks. Some are doing it on revenue cycle issues.
We're doing one right now.
Right now on revenue cycle. And that specifically looks at reducing the number of denials for services because we didn't have prior authorization. If you recall, one of the things that Brian talked about doing was to reduce it significantly, and I think you've accomplished that.
In the ER.
In the ER. So taking taking very narrow focuses and looking at trying to fix our process can have significant impact on the business. So we're actively talking, we've had several meetings, and I present, they have agreed to have Tom and Torp and Griffin prepare a JPA agreement for the other three hospitals in Oregon, virtually identical to what we had for the California business. So it is progressing along pretty well. I think that if we can have that done in the next month or so, we'll probably need to consider having one of you become the designee to sit in that JPA board for the Oregon hospitals, just like Judy is the designee for the California hospitals. So that's moving along pretty well. We have a next JPIE meeting for California for April 20, and that'll be at Majors Memorial Hospital. So we're getting some headway. We're working on a physician group, and we talked about this in the past, so we're making good progress. We also tomorrow graduate our first class of CNA students, where we have a student from California. So this is a big deal. And as we keep finding ways to work together, this will enable us all to find other opportunities to not bring in a big organization that says, thank you very much, you are now a spoke to our company. Remember, that's, in my view, a very vital thing.
That's a good segue.
The ONA negotiations begin April 25th and 26th. Hopefully we'll be able to move that along as quickly as we did with Teamsters. When we had that went very quickly. We don't want to have this drawn out process. But we're hopeful on that process. The auxiliary has recently made 3 grants to purchase items for various departments. I don't have the exact list there. I don't want to steal their thunder, but it's very exciting that they're using proceeds from the gift shop and other activities that they are in. As you know, they have been very, very generous over the years, and they have a plaque that lists many of the donations that they have made in recent years to the district. So we're very, very appreciative of what they have done. And it's about $11,000. Thank you very much. So that's a lot of money.
It is.
So it's very, very much appreciated. And we appreciate it. But thank you. I don't know if you want to have an update on the DME activities. As Cheryl said, there's a lot of activity going on. We purchased a van, and we got significantly less than what we had originally seen in our budget. It's about $10,000 used, but it will meet our needs. Just in the negotiations for getting oxygen and how we're going to be able to supply that without even getting DME working, it's going to be close to in savings for a 5-year period. It's a significant amount of money, just in renegotiating our oxygen deal that we currently are using. So I think that there'll be a lot of benefit for it. We're looking at where we're going to put the facility. And we have several different options. We're not ready yet to say where we're going to go yet. Targeted several different options, but we're looking for the most economical. But by looking at that, it has caused us to look at lots of areas. What could we do differently in terms of where things are located? Every time we start doing that, the dollar signals start bouncing. But as Teresa said, with the expansion of our infusion program and the prospect of needing more patient beds because of the increase in swing beds that we anticipate, we need to plan on relocating our infusion therapy service. It's currently in a patient room. So we thought about, well, it could go in the space that was vacant. It will be vacated by long-term care as they move out this section. What do we do in the other? Are there options that we could consider? And so we constantly we're looking at different options. We are not yet ready to come to you with a plan of not only what we would do, but where we would move it to. But we're actively looking at it. So some of it is, a big example is our rehab department. They continue to see, and you saw the numbers, that they keep doing more and more patients. That's really great for our community. But when we are taxed with where we put services, when we get our speech therapist, this person takes the job, where are we going to put him? We got to figure that out. Do it quickly. So I hope to have a plan for you. Do you want to get monthly updates on D&E, or is this helpful?
Thank you.
I've been asked to serve on what's called the PATH Task Force. And this is part of the Oregon Hospital Association, essentially made up of leaders of all the large hospital systems in the state. So that's St. Charles, Kaiser, Peace Health, Samaritan, and 2 independent hospitals. One is Good Samaritan in Hermiston, and us, representing district critical access systems. So we're the 2 voices for that. The purpose for this is to deal with an anticipated demand in 2017 when the legislature goes into session. It's anticipated there'll be a shortfall of upwards of $500 million. And with the Affordable Care Act taking a lot more, we have more covered people in the state. Hospitals have no longer had as much of a charity care cost as we have seen. It's been a reduction in charity care. For some of the bigger hospital systems, that has meant they have had significant improvements to their bottom line. And so there'll be people asking for that. So I will report back to you the findings of this organization. But I think it's good that our voice is heard. And that's important. Last thing I have to bring up is I received yesterday a letter that says, please accept this donation to Lake Health District with the following reservations for the use of these funds. It is our desire for this to be seed money to establish an employee education enhancement fund to cover educational loans and grants in a similar manner to the Patricia E. Johnson Restricted Fund. It is to be used for students that are employees of the district seeking education in non-nursing fields. This is to be administered by the Lake Health District Board of Directors. The donors wish to be anonymous, and the check is for $30,000.
Well,
So one of the things that we would like to be able to do is to set up a fund to ask other members in the community that would like to participate in this to help expand the increasing need that we have for employees that are very interested in continuing education. So this is a very, very exciting donation.
Very generous.
So we're very, very pleased with that. Do you have any questions you'd like to ask?
Charlie, the most important thing you left out. Have you figured out how to get the name tags on both sides?
It's Leslie's job.
Leslie was working on that project. We had talked about it.
Oh.
And,
We're going to talk later, Cheryl.
So, but yes, we are, there's a couple things that we are doing with our name badge. If you recall, about a year ago, when we were looking at our budget, we had in the budget the opportunity to have what's called a single sign-up. Nurses, doctors, anyone that signs on the CPSI system, often, if they move from computer to computer, the emergency room or departments, they frequently have to sign a lot, enter a lot of keys. There's software, and it's expensive software, but if you bring your name badge in front of that, you also have to go to use your thumb. Print, not everybody likes that. But you use name badge and have this software allows for single sign-up. As part of our attempt to meet meaningful use, we gave it as a prize that we met the meaningful use requirements last year. Agreed that we would go ahead and get this software. We met meaningful use, and so we will be doing it. It's going to greatly help our nurses. Not all the physicians were on board, but it's really going to help the nurses. So we need to make sure that the single sign-on works with the name, our picture on the other side. That was the part that we couldn't verify until after the problem was all over. So that is our plan.
Okay.
So Leslie's giving 30 days on the receipts back. We should give her the same for this.
I do want you to know, though, that my name tag is facing out.
It wasn't earlier.
Yeah, it was.
No, it wasn't.
No, it wasn't.
I'll agree with you, Joe.
Oh, well, now you're ganging up on me. You're gonna
Yeah.
press my first evening, I get out of jail free card. All right, fair enough, 30 days.
Brian, did you have anything? I haven't heard from you.
I can give an update on our claims with missing information I talked about last meeting. So in December, our claims with missing information was at over $1 million. I can do it off the top of my head. We're at 568,000 right now. So each month we've reduced it by 200,000. A lot of the claims that are unchecked are due to issues with insurance companies. Medicare was a big one. This last month we received 968,000 from Medicare. Our average receipts from Medicare is in the 600,000s. So our billers have been working very hard on cleaning up our AR. We have good progress. We still have a long ways to go. Our new staff, having that extra biller has helped a lot. We have a new employee that just started in the ER that's checking insurance verifications, working with the unit secretaries to help improve the insurance information in the ER. And we've included her in our lean project that Charlie was talking about. The lean project is analyzing the ER claims, so for denials, and she's looking at the outliers, that an outlier is a claim that is delayed. So she's analyzing, picking out certain claims, a certain amount of claims per month, and it really helps her educate how important her job is.
Okay, thank you. Well, it's 26 after 8, and you'll go take a 10-minute recess, come back and go into executive session under ORS 192.660, 2A and C.